Hi, I'm Ashley Pollock. I'm going to be presenting seizures to you today. I'm the CNE over at City Hospital for Ambulatory Care, Clinical Treatment Center, Women's Health and Breast Health. I was the CNE on 6300 here previously, and my other history is in critical care. There are 65 million people in the world who suffer with epilepsy. 6 out of 10 people with epilepsy have no known cause. What is a seizure? Seizure is technically a burst of uncontrolled electrical activity that disrupts normal functioning of neurons. It's often called electrical storm. It can result in altered consciousness, behavioral changes, and or muscle jerks. People can have just one seizure, two seizures, or when it's recurrent and unprovoked, it's considered to be epilepsy. There is actually a single seizure clinic in Saskatoon for those people who only have one seizure. What are the risk factors? There's many risk factors. Intellectual or other developmental disability. Specifically to this, people who have developmental disabilities typically have some kind of injury or developmental change to their temporal lobe. And we know that the temporal lobe is one of the most common points of epileptic seizures. There is a definite correlation that they are aware of there. Any anoxia, so people who code have any anoxic brain injury, stroke, any major head trauma, CNS hemorrhage, infection, all of those people who have burst aneurysms that come in with meningitis, dementia, and that's usually a vascular dementia, brain tumor, and congenital or familial. So all of those are just some risk factors, and there are many that we have no idea. Of note, anyone who comes in from a trauma that has suffered head trauma of any sort will 99% of the time have a seizure. This seizure may not happen right away, but it will happen. So you'll either see it right away in the first 2-3 days, or it can happen weeks later as the brain is healing. Phases of a seizure. Not all seizures will have all of these phases, but the ictal, postictal, homeostasis, that always remains the same. Okay, prodrome. Up to 20% of people with epilepsy will have a prodrome. So this is not part of the seizure, it's before the seizure. These are subjective feelings. People are aware that they're going to have a seizure. It's the same every time. There was one nurse who did orientation on 63 last year whose family has a huge epileptic history, and her brother had a prodrome. And his prodrome was feeling like he was being chased by a murderer, and that would happen 48 hours prior to the seizure. Even though he knew he wasn't being chased physically, cognitively, that feeling, that anxiety, the adrenaline was there for 48 hours. Aura. Now the aura is the very beginning of the seizure. So prodrome, they haven't begun seizing yet, can happen up to 48 hours. Sometimes you can stretch to 72 hours before the seizure. Aura is the beginning of the seizure. Some people have it, some don't, most will. It depends on where the seizure is in the brain, the seizure focus. Common auras, déjà vu, jéma vu, feeling like you know someone or you've been somewhere before, hallucinations, and ringing or buzzing sounds. There was a patient on 6300 who had her first seizure. She was in OBS and stroke OBS, and with the seizure that she had in stroke OBS, they had noticed she kept saying, stop the telephone. The telephone keeps ringing. And at the time, they didn't think anything of it. Everything's ringing. You know, you have monitors, call bells. But when she was moved out to the ward, it just so happened the same nurse was on taking care of her. And she started saying, turn the call bell off. Someone just turn the call bell off. It won't stop. And then she seized. So because of that, we know that her aura is ringing, a ringing sound. That's why it's very important to actually watch the seizure, pay attention to what your patient is saying if they are having a seizure. Go back and ask what happened prior. So the ictal phase, this happens within seconds or minutes of an aura if the aura occurs. So with the ictal phase, a seizure can stay in the original area, which is a focal seizure, or spread to the other hemisphere of the brain, which is a generalized seizure. So when people have seizures, it's usually one little focus that is the cause. If it's one focus, it's considered a focal seizure, and all the seizure characteristics will depend on where in the brain the aberrant electrical activity is happening. Some people go straight to generalized, which means it's both hemispheres. And you can also have seizures that start as a focal seizure and spread to the whole brain. So they start as focal and become a generalized seizure. Every seizure is different. Postictal is the recovery phase, return to baseline function. So it's important you know what they were like prior. It can be immediate or occur over a few days. These patients, you've seen them, they're drowsy, confused, have some delayed responses. To remember though, if it's going, people should start looking better within about 20 minutes. And if they aren't, you need to do more investigations. When people seize, their muscles are working really, really hard if they're having a grand mal or any kind of tonic or clonic movement. So I would be concerned as to whether their lactate is actually up. It does happen. The other thing that can happen with prolonged seizures is MIs. So if they're not getting better significantly within about 20 minutes, I'd be concerned and do some more investigations. Sleep triggers, there's many. Sleep cycle, insomnia, oversleeping, stress, illness, flashing lights, hormones, certain foods. Some people seize at a specific time of day or night. Why, they don't know. There's so much we don't know about. Types of seizures. So this is new from 2017. They used to classify them, what you're probably familiar with as the partial seizure, tonic, clonic, or grand mal, petite mal. They don't do that anymore. Now they have 3 different kinds. They're more focused on, they've changed their focus from making a label to what does a seizure actually look like. They actually have a brain bank. It's the only one of its kind in Canada, and it's in Saskatoon. So when Dr. Wu goes in and takes out a seizure focus, because if they do surgery and they're able to identify a single focus of a seizure, they will try and take out just that area of the brain instead of a whole hemisphere. That little piece of brain is sent to the brain bank, and when they go there, they do tests on it to see which medications work better on that type of seizure. So it's very important that we know exactly what the seizure looks like and the characteristics of the seizure. And that's the intent of this scale now. So you can have a focal onset, a generalized onset, or unknown. And we'll go more into those. If you notice though, focal onset, they can be aware or have impaired awareness. Generalized is always impaired. And then you start talking about the motor characteristics and non-motor characteristics. So when a patient seizes, you're going to ask yourself 3 things. 1, was the patient aware throughout? 2, what did the start of the seizure look like? And 3, did the symptoms change as the seizure progressed? So did the patient remain aware throughout the seizure? If yes, then it was a focal onset. So focal means one area of the brain that has the aberrant conduction. The whole brain wasn't involved, so they were able to maintain some kind of awareness. When someone starts to seize, something that is a good thing to do is, can you say your name? Can you give me a thumbs up? Can they interact with you in any way? That's something that you can, that's a way to tell if it's focal or generalized. As soon as a seizure involves both hemispheres, it's generalized and it will be impaired awareness. The brain does no longer functions normally. And if you blinked and missed the start of the seizure, it's classified as unknown onset. Key points: any retained awareness indicates the entire brain is not affected, and it indicates whether the seizure is focal or generalized in origin. Because remember, you can go straight to a generalized seizure, or you can start focal and go to generalized, or just stay with a focal seizure. So now what did the seizure look like? So anything here in pink is indicative of a focal seizure. So in general, you're looking at motor and non-motor symptoms. So motor symptoms, tonic, which is flexion, clonic, jerking, atonic or drop attacks. So those are the people who you may see walking around with helmets on. Their seizure is they lose all tone in their body, just drop. So the helmet is on just for protection of their head. And myoclonic or brief twitching. Myoclonus is most common post-anoxic brain injury and post-significant anoxic brain injury. It's a different movement from a tonic-clonic. The best way I can describe it is if you ever feel like you're falling when you go to sleep and you jerk, that jerk is myoclonus. These guys also do something called automatism. So these are the just like the extrapyramidal effects you can get from some high dose psychiatric medications. Pill rolling, very common, and lip smacking. You'll see, and a lot of patients who have epilepsy will have behaviors like this prior to the actual onset of the full motor function, the full motor jerking. You'll often also see a forced deviated gaze. So all of a sudden they'll just look to the corner and just stare. And you can't call them back. They won't move their head or respond. So that's motor. You're also going to look at non-motor symptoms. So anything like a change in emotion or cognition, feeling goosebumps, having a lack of movement or behavior arrest. People can have no motor symptoms, but can have a change in emotion, cognition. They can have a behavior arrest, meaning we can be talking just like this and all of a sudden there's nothing. And they just stop everything. There's no interaction. That can be their seizure. So just be aware that when you look for patterns. So now generalized seizures. Symptoms in green are those of generalized. So now you notice in motor symptoms, we no longer have the option of automatisms. So when you have automatisms, again, it's some kind of organized movement. And to have any kind of organized movement, you need to have some kind of organized brain function. And with a generalized seizure, we know that. So that's no longer seen with a generalized seizure. But non-motor symptoms, here's where you can see absent seizures. So the staring, this can be with or without myoclonic twitches. Now, absent seizures, most common in children, it's often the first kind of seizure they will have, and it will progress through life to more of the motor symptoms that you'll see with the grand mals. Very rare for it to begin in adulthood, although it does. One thing to note is that sometimes kids who are in school and are classified as daydreamers may be having absent seizures. It's missed more than it should be. So just of note. And with the myoclonic twitches, with absent seizures, you're usually looking at eyelid twitches. Unknown onset seizures, again, you blinked, you missed the onset of the seizure, but you know they're seizing now. By default, the motor symptom is tonic-clonic, and non-motor symptom would be behavior arrest. So if the person has just stopped doing everything, you would say unknown onset seizure, behavior arrest, or if they are having all, you would say unknown onset, tonic-clonic, because you don't know any other details. You haven't seen any more that you can lean on to describe that seizure. How do they diagnose it? They diagnose seizures with thorough and accurate description of seizure activity. So there is a seizure log. So please, 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 as much detail as you can, time the seizure. What did it look like when it started? What kind of movement did you have? Did they have vocalizations? There is a very specific kind of vocalization you'll hear. It's kind of a grunting sound as the air is pushed out, forcibly pushed out of the trachea as the seizure begins. These people remember that they need oxygen, put a non-rebreather on, but there is a very specific sound they will make. They do EEGs to look for abnormal electrical activity in the brain. I can't read an EEG. I've seen many. I couldn't tell you if it was seizure activity or not. You get a lot of artifact. That's why we have specialized techs that do that. We do have outpatient EEGs. Even people in hospital will go down if they just need a quick 20-minute read. And 6,000 or 6,300, I apologize, has two tele beds where they actually have the camera and everything on, and they can watch as the patient wears the EEG leads. CT MRIs, these are just looking for structural abnormalities or disease processes. These are people we know they seize, but we're looking for why. So do they have something that can be fixed? And blood work. Hormonal and electrolyte imbalances, underlying medical conditions, sodium, changes in sodium, high or low, can cause seizures and very debilitating seizures. Note about people who are going through delirium tremens, withdrawal, alcohol withdrawal. Alcohol is a CNS depressant, so it actually depresses the GABA receptors. So when you're seeing people start to come out and start to seize from alcohol withdrawal, it's because their brain usually, because of their alcoholism, lives in a state of depressed activity. So now we've taken that away totally, and what would be normal activity for you or I is exceptional activity for their brain, and their brain can't handle that. So all of a sudden they have normal functioning, and sometimes it even overshoots, and that's when they start to get seizures. So just note, benzos. Alcoholic seizures are very, very bad. So nursing care, don't be Kermit, but during the ictal phase, so the actual seizure, you're going to stay calm and stay with the patient. Never leave the patient alone. Make sure all the side rails are up. You're going to assess awareness. Hey, hold out your hands, wiggle your fingers. What's your name? You're going to time the seizure and observe the behavior. Protect them from injury. If they're half off the bed, if they're sitting at the side of the bed and you can't get them on the bed, get them onto the floor. Just try and keep them safe. Loosen anything tight around their neck. Do not restrain. Do not restrain at all. Don't worry about getting anything out of their mouth. Don't worry about getting an oral airway in. Just let the seizure happen and keep them safe. You're going to call for help. Use the patient call bell, pull it out of the wall, yell anything to get someone else there, but just make sure that you keep that patient safe. If there's someone who you know has seized before, if there's someone who could possibly start going through DTs, be careful how you set up their room. Don't put anything between them and the bed. So if they're up in a chair, don't have the chair facing the bed with the table in front. If they seize, you're in a world of hurt, and so are they. There's nowhere to go. So just be wary of how the room is set up, and that you do have all of the bed rails up, or they can be put up quickly. In the ictal to postictal phase, you're going to get oxygen, so it's a non-rebreather. Put a non-rebreather on it, flush. Again, with COVID, you're going to put on a procedure mask over top of it, and take a set of vital signs. And you're going to assess the postictal recovery. Reorientate, reassure, assess them for injuries. They are NPO until they are able to swallow, and keep them NPO for quite a while. Check with your physicians, do your Yale swallow assessments, but err on the side of caution. And you stay with the patient, of course, until they return to baseline, not when they start to get better, but until they are breathing and talking well. They will be stridorous. Sometimes you may have to do a little jaw thrust to open up their airway for a little bit just to get extra oxygen in, but make sure that they are getting oxygen. Their brain needs it badly. And document. You're going to get really concerned when the seizure lasts longer than 5 minutes. That is by definition an status epilepticus, which is a seizure that won't stop. If consciousness or regular breathing does not return after the seizure has ended, they should be breathing on their own when the seizure has stopped. If the seizure repeats without full recovery between the seizures, so when someone seizes, they should return to full baseline. If they don't and they seize again before that, that is status epilepticus, and that is an emergency. Confusion after the seizure persists for more than 1 hour. Now you're looking at anoxic brain injury, increased lactate. Did they have an MI that's caused an increased lactate? Lots of things that need more investigation. So you've paid to the doctor because you're concerned. If the patient is still seizing, they may order benzos, Ativan or Midaz. Typically on neuro, they prefer Ativan. It's just a bigger bang for your buck, lasts a little longer. It's a higher efficacy for stopping the seizure, but either or any benzo will work, and it will be 1 to 2 milligrams IV, and you give the full because you need to stop that seizure and stop it now.